Нет, тут самое. Я вас представлю, скажу. Так. Так, здравствуйте.
Good afternoon once again, dear participants. We are starting on our second session. It is called Early Intervention as a way to include children with disabilities into educational process. The moderator is Gulzia Kaybaevna Bidatova. She's candidate of medical sciences and she's the head of office, project office on intersectoral cooperation for the roadmap on integrated support to children with disabilities, which was approved by Prime Minister in 2020. This project office is designed for the support of intersectoral cooperation in providing assistance to children with disabilities. The topic of this talk is improvement of help for children with disabilities as a way for creation an effective model for intersectoral cooperation. Thank you, Rosa Ayjanovna, dear colleagues, dear participants. Could you put up the slide, please? Allow me to greet you and thank the organizers, Rosa Janova and her team, for organizing such an important event and for her commitment to work on improving the lives of children and the integrated help to children with disabilities. As you know, early intervention is a system of various measures aimed at development of young children with developmental disabilities or with appropriate risks, and measures geared at the support of such children's parents. The plasticity of the brain determines a lot of potential opportunities. Early medical, psychological, and pedagogical assistance allows to more effectively compensate for disorders in psychophysical development of a child. But in order to provide the above assistance in a timely manner, it is necessary, as I say, to reach it. We need a system of detection, early diagnosis, and early intervention. Analysis statistics in Kazakhstan shows a significant increase in the primary disability rate, which indicates ineffective early intervention and assistance to children. Currently, Kazakhstan has a sufficient amount of regulatory documents for the detection of and early diagnostics of disorders in children, but there is a lack of interaction between different ministries. Analyzing the current system of assistance to children with disabilities, experts have identified first, screenings are not provided in full volume and sometimes not provided at all. The reason is supposedly no lack of funding, and services are provided wholesale without per capita funding. Most importantly, there is no commitment, both regionally and centrally, and there is an insufficient understanding that lack of a system of early detection and intervention provides a growth of children, of the number of children with disabilities. Second, after detection, there should be early diagnostics process and follow-up, early rehabilitation. The development center should be the main the main point for the child support. Currently, even though there are follow-up cabinets and developmental offices, there is no functional content to these offices. There is a lack of infrastructure for rehabilitation centers and correction offices. First of all processes are happening at the healthcare side. In early intervention, there should be integration with other social protection and education services. Based on the above, to eliminate gaps in early intervention, to upgrade integrated assistance to children. On the initiative of Aruzhan Sain, the Commissioner for Children's Rights, there was developed and approved by the Prime Minister of Kazakhstan a roadmap on improving assistance to children with disabilities, which covers years 2021 and 2023. The aim of this initiative is to enhance intersectoral cooperation. In April, a project office for guidance and monitoring was set up. We need to develop conceptual approaches to increase the effectiveness of the implementation of state policy through upgrading the system for providing assistance to children and through enhancing intersectoral cooperation. The roadmap plans 56 events. The Ministry of Health is the main executor for 25 points, Ministry for Labor and Social Protection for 4 points, Ministry of Education for 7. One activity is assigned to Ministry of Agriculture, and local executive bodies are responsible for 19 events. The key areas in the roadmap are activities for prevention of disabilities and for early correctional and developmental assistance, measures to improve the organization of rehabilitation services, measures to provide equipment and medicines, measures for training, measures for gluten-free food introduction. In the first 6 months of the year, a number of important events have taken place. Some are still in progress. Amendments have been made to the Order of Minister of Health on the organizing of the screening. In terms of revising audiological, psychophysical screening, experts plan to include selective screening of newborns for hereditary metabolic diseases and to strengthen the follow-up of these children. As a result of discussions, the order has been signed and the work group who initiated the revision, continues its work. Work is underway to make changes to the Order of Minister of Health dated January 29, 2017, on approval of standard for organizing pediatric care in the Republic of Kazakhstan. In terms of organizing the activities of child development rooms or centers, functional duties of specialists of this office. As noted above, currently child development rooms are not fully functional and do not perform the main functions of screening and integration with other departments. Also, proposals are being worked on for making amendments to the law of Republic of Kazakhstan on social and medical pedagogical correctional support for children with disabilities. In 2004, the government of the Republic of Kazakhstan excluded the function on the coordination of authorized bodies, interdepartmental interaction in matters of social and medical pedagogical correctional support. This issue of reintegrating these functions back is raised once and again. Also, proposals on equipment for rehabilitation issuance to children is being discussed. This question is very important for people with disabilities. Currently, we don't have an adequate system for selecting support equipment. We need to use the international classification, the ICF. We need to understand what rehabilitation products can be purchased through the national system. So it's considered that the selection should be based both on general criteria and individualized one. The procurement of products, is an individualized process. Like when you buy glasses, when you determine what kind of glasses you need. We work on the integration of processes. So there are difficulties accounting for children with various disabilities because current informational systems do not have information on the disability, on the degree of disability. Also very relevant is the question on training and retraining. Analysis of work as part of the roadmap has shown that the systemic work has not even begun in this area, even though the roadmap is already being implemented. There is no regional training plans. There is no staff retention plans. There is no coordination of this work by the authorized body. The order of the Republic of Kazakhstan Ministry of Education and Science, number 70, which relates to the approval of norms of equipping preschool, secondary, and educational organizations with equipment and furniture. So questions related to providing medicines for children with rare diseases should also be tackled. By implementing all these measures, we provide the child with integrated assistance. Early intervention expands the child's opportunities for education, for acquiring a profession, and it contributes to the development of the individual's autonomy, which eventually contributes to the country's economic growth. And allow me to start with my moderation functions. Today, we will discuss very important questions related to early interventions. This is a very important stage. This stage determines the root and the fate of the child, as it were. Our session is to answer specific questions. The questions for discussion are how the important components of early intervention should be resolved. What are the ways to resolve problems? What should we do to make early screening a state system? So I propose the following format. After first hearing speakers, we will discuss. Speakers have time limits, and please observe those. And allow me to start. Allow me to give floor to the next speaker. But before I do that, I would like to say that for reforms in the country, we need to study international experience. Of great interest are the experiences of neighboring countries because we inherited same problems. I would like to give floor to speak on screening and early intervention in Russia. The chair of laboratory of integrated assistance to children, Institute of Pedagogics of Moscow, Yulia Rozenkova. Thank you. Before I start my presentation, I would like to congratulate dear Rosa Ayjanovna on her anniversary on behalf of the Institute of Correctional Pedagogy and on my personal behalf, and also to congratulate Satur, the Satur Center, on its 25th anniversary. I wish you, Rosa Ayjanovna, great health. I wish you productive work for the good and benefit of your country and for the benefit of families with children with disabilities. And now allow me to start on my presentation, which is called Organization of Screening Diagnostics of Children in the System of Early Assistance to Children in the Russian Federation. Problems and prospects.
Multidimensional system for monitoring the development of children of first 3 years of their life and screening for the development of children in the early care system of the Russian Federation, as in most countries of the world, uses the capabilities and advantages of the national healthcare system. And it means that it has the same issues that are possessed by the national system of healthcare in identifying children with disabilities. All children born in obstetric care facilities in the Russian Federation undergo neonatal screening, including methods for monitoring child development and screening examinations, and some hereditary genetic metabolic diseases and hearing impairments are being identified at the expense of the federal budget. In the regions, mass examination of newborns mandatorily for 5 hereditary diseases is carried out, as well as a mandatory universal audiological screening. Perinatal centers currently use ophthalmic screening methods primarily to detect children with vision impairment, severe vision impairment, such as retinopathy of premature babies. For all children born, risk factor maps have been developed, which are filled out in the maternity hospital. The card is then transferred to the clinic, where systematic observation and examination of all children is carried out. If a newborn child has positive results during neonatal screening, then the parents with the child through the children's clinic are invited to a medical genetic consultation for a second examination. And then if the screening, if If repeated results confirm the presence of a disease, the child is registered for observation and treatment. And widespread introduction of the program of audiological screening of newborns is, for the Russian Federation, one of the key aspects of timely identification and adequate rehabilitation of children with hearing loss and deafness. The order of the ministry on conducting universal audiological screening was approved by the order of the Ministry of Health and Social Development April 1st, 2008. Before, in Russia, they were doing a screening based on risk factors, which one could say failed. And only the universal screening gave an opportunity to truly identify children with hearing disabilities. The audiological screening is done using registration of autoacoustic emission, usually in the 2-3 first days of life. And further on, it's done at 4 to 6 weeks of all newborns to children who, for health reasons or other reasons, have not been examined, and children who have received a positive or questionable result during registration of autoacoustic emission in maternity hospitals and for children at risk. In the second stage, in screening is carried out within 3 to 6 months after birth. Next slide, please. The organization of control over the development of children and preventive medical examinations of children is entrusted nowadays to medical organizations, regardless of their organizational and legal form, providing primary health care services to minors and licensed to carry out medical activity. The periodicity of medical examinations and control over children's development is laid out in Decree number 307 of 28th of April 2007, and that has helped manage these children. That order of the ministry lays out everything needed to monitor the development of the children. And then the order on the monitoring of the children within their first year of their life, medical examinations, including in their education organization, also give an opportunity. There's suddenly no sound. I apologize, my sound was off. Right. And other orders, including the order of minors carrying out medical examinations, also gives an opportunity to control the development of the children and identify such children. Next slide, please. So the issues in the early assistance systems, it is currently, we've seen it very obviously in the remote territories and settlements, and the modernizing of the system of healthcare of the Russian Federation, which included first aid provision points in the rural areas. And the remoteness and the impossibility of this family with the child to go through a screening at a hospital or outpatient centers or regional or district hospitals is what is taking a toll on the results and the effects of early assistance, including in the rural areas of the Russian Federation and remote areas of the Russian Federation. And that impacts also a much later arrival of this family with their small child to the system of early assistance. And I can give you examples where children with hardness of hearing were identified during uh, giving birth. However, additional screenings of hearing um, were not possible for the family to undergo because they live in a remote location, 150, 200 kilometers from those large hospitals where they can undergo the screening. And unfortunately, then in the early assistance system, we get by 2 or 3 years old a severe child with a severe difficulty hearing that lives in a rural area, in spite of the fact that pretty much they were identified at birth. But there was no possibility to repeat the screening, and there was no opportunity to have that family arrive and be included into the system of early assistance to the corresponding centers. The second group of issues has to do with a shortage in some regions of the Russian Federation in polyclinics, outpatient clinics, children's hospitals, of pediatricians and neurologists, which is something that also affects the outcomes of identifying children. And the third problem group is characterized by, and I heard the speech of our colleague from Kazakhstan, same problem, interagency interaction, and the lack of such, or in mechanism that is not streamlined of interagency interactions of the healthcare system, social protection system, and education, a lack of development of contracts, algorithms, and regulations for interaction and redirection of the child's family in the first years of life to receive early assistance services creates significant problems in the operation. The early assistance system in many regions of the Russian Federation, we often face under examination or not timely examination of children in their first years of their life who the early assistance system itself on a diagnosis stage has to use the screening system. And the Institute of Correctional Pedagogy developed a two-level system for analyzing child development. Next slide, please. The first level is methods of monitoring the development of the child, including the use of a map of risk factors and diagnostics of the neuropsychic development of children as a method of monitoring development. And at the second level, various differentiated screening tests focused on certain areas of the child's development. For example, methods of screening hearing of children, methods of screening visual function, methods for identifying autism spectrum disorders, and methods of screening speech development of children, etc. in identification of possible developmental problems in children in the first years of life using developmental monitoring and methods of screening for development, and its confirmation or refutation involves the use of clinical diagnostic methods of research, and therefore the redirection, once again, of the child and their family from the early assistance system to the healthcare system. The organization of such work requires the redevelopment of mechanisms for interdepartmental interaction, coordination of the work of the early assistance service with the pediatric service of the children's polyclinic, and neuro specialists. Thus, the organization of a system for screening the development of children in the first years of life, to a greater extent today, requires not so much diagnostic methods, although they are needed. It is required to develop them, but it mostly needs interdepartmental interaction and coordination of the activities of healthcare institutions and institutions of the early assistance system. It is true that in modern methods and means of transferring information and interaction of specialists, this is what is required. Thanks for your attention. Thanks for inviting me to this high level conference. Thank you very much for Ms. Yulia. You are right that when organizing screening of children in the early years of their life, it should be done by the medical commission and by social protection. And prevention of disability of children is important, and the quality of life depends on it. And allow me to pass the floor to the Doctor of Medical Scientists, Professor, head of the Republican Medical Genetic Consultation at the National Center for Obstetrics, Gynecology and Perinatology, Svetova Gulnara Salavadovna. She's going to talk about organizational technologies for early prevention of child disability from genetic disorders in the Republic of Kazakhstan. You have 15 minutes.
Dear colleagues, I would like to thank the hosts of this conference, dear Rosa Janovna and Guzia Kairbaevna, dear colleagues. I would like to thank you for this opportunity. I'm a geneticist, and therefore I would like to address how the medical genetic service works to decrease the rate of children's disabilities. We all know that the organizational healthcare strategy to prevent disability and mortality consists of 3 levels, and the first level of prevention, the primary it is the primary prevention. It is the pre-pregnancy prevention. The secondary prevention is aimed at detecting potential genetic disease in the child. And the third level prevention is aimed at the correction or restoration of lost functions. So our practical healthcare is engaged in the third level prevention. We have health centers. We spend a lot of money on introducing new technologies, but we know that not all developmental disorders can be corrected. But even post-operative correction of the heart disorder and the subsequent rehabilitation is not always effective. Therefore, the main focus in this stage should be on the primary prevention. Why on the primary, not secondary? Because we know that unfortunately the prenatal diagnostic is a very effective method, but unfortunately it is based on the abortion of a genetically anomalous fetus, and it has a very big impact on the woman. And as long as we are focused on the third level prevention, there can be no reduction in children's disabilities. Next slide, please. You can see here the structure of uh, congenital developmental disorders. Over the 10 years, developmental disorders have come down by 14%, but the share of folate-dependent disorders has risen from 51% in 2010 to 70% in 2020. By 8.1 heart disorders, and have increased. And this structure clearly shows that our state, that the primary diagnostics, primary prevention is either absent or malfunctioning. And this is one of the nosologies of the prenatal screening and our effectiveness, our performance. We can say with pride that the frequency of disorders with the so this particular disorder is lower than in the U.S., in Japan, and in Russia. If we didn't have for the prenatal diagnostics, this indicator would be several times higher. And I'm a person who's responsible for the prenatal diagnostics in Kazakhstan. But as a person, as a citizen, I know that behind it is abortions and unborn children. 463 pregnancies were stopped last year due to neural tube disorders. I'm very happy for our Russian colleagues. In 2016, they issued a clinical protocol of the Interdisciplinary Association of Specialists on pre-gravidory preparation. And it clearly states that it's a whole complex of activities, lifestyle, habits, alimentation, and very importantly, a course of folic acid, which is prescribed to parents based on their genetic dose. And in this protocol, it is recommended to conduct genetic analysis. Our patients say to us, we have been taking vitamins for the whole life, and we don't believe that any routine intake of vitamins can help resolve our genetic problems. And data of multi-center studies and meta-analysis have shown that of parents who took folic acid before inception and those who did not take, the frequency of children with neural tube disorders is reduced by 70%, with autistic disorders is reduced by 40%, and cleft palate frequency is decreased by 47%. So it is indeed very effective. Next slide, please. So something happened to my screen here. everybody is for the pre-inception preparation, but there are issues that we need to tackle all together. My next slide will be showing the results of our genome studies. These are data from the genomic basis for 3,600 Kazakh people. This database is hosted by the Center for Obstetrics, and this data shows that only 35% percent of our people have favorable favorable genotypes for folate disorders, and the rest need to take in folic acid. This slide also shows that the Kazakh population, in terms of minor alleles of the metabolic genes, is intermediate between Asian and European population. And dendrograms of the genetic distances that we built clearly shows that Kazakhs form a unified cluster with the populations of Europe. This is shown by the slide on the right, and the populations of Finland, and we are absolutely far from the populations of America and Africa, but also from Eastern and Southern Asia. Our studies have shown that the Kazakh population does not have genetic basis for a higher frequency of folate-dependent disorders. In 2010, the World Health Assembly published a report on first actions. Each country should have a monitoring program for it should have programs for supplementing food with folic acid, and this program is paramount to national security programs. In the Mars Protocol of the Russian Federation, it is clearly stated that non-prescription of the folic acid, according to the federal law, is considered as a defect in rendering medical assistance. And it clearly states that in such and such group, the dose is 400 micrograms per day, and in the high-risk group, the dose can be increased to 4,000 micrograms per day. In our clinical protocol, we have single dose, 400 micrograms per day, and it is clear that this dose does not meet any standards. Next slide, please. Now, what is the situation in our republic, including that with fortifying products? In 2021, these programs are already in place in about 60 countries. There are national guidelines, there are clinical protocols. In our country, we have a clinical protocol for diagnosing and treating and for managing pregnant women. It is dated 2016, and it shows the 400 microgram dose, and it's not fit for anyone. And there is already data that as a result of this national program for nutrition in US and Canada, they decreased the number of defects of neural tube by 25-30%. And the fortification of flour in Kazakhstan was introduced in 2009, but we don't have any official statistics. The only thing we found is that in 2016, only 40% of flour were enriched with folates. Next slide. And this is the last slide. The primary tasks, primary challenges. We understand that we cannot, uh, health specialists or educational specialists cannot resolve this issue. This requires interdepartmental, intersectoral cooperation. This is what we can resolve all together. We need to develop programs, and these programs should include fortifying food and fallout prevention. We need a national guidelines for pre-inception preparation, and we need to show we, we need to include molecular genetic diagnostics of metabolic diseases. The fortification of food will give us another 300 to 400 micrograms per day. This is great help. Also, educational programs for the population, for school and university students will be very helpful. Thank you very much, Gulnara Salavatovna, for a very informative presentation. Your presentation, I think, should be the national plan. I think all these recommendations should be included into state regulations. Screenings play an important role in identifying disabilities in children. Next speaker is Professor of Clinical Specialties of the National Medical University, Korlan Zarlikova. Korlan Zarlikova will speak about the role of screenings in preventing neonatal death. Korlan Zarlikovna is one of the authors of the roadmap of roadmap for program for decreasing child mortality. Let me welcome you to this conference. We are now at a critical point where we need to come up with a common algorithm of assistance. Gulnar Salavatovna has just said that even before the child is born, before the child is incepted, we need to raise very important questions such as planned pregnancy. In my talk, I took just one small fragment. I studied all the presentations and would like to say to you that to talk to you about the role of the screening. And we have been making quite a number of changes into the implementation of screenings. So what is a screening? Screening is identification in otherwise healthy population of people with high risks of disease or conditions. As a result of screening, there are developed proposals for early intervention and treatment, and subsequently it leads to reduction in neonatal mortality and disabilities. This screening was developed on the basis on regulation on social medical correctional support of children with disabilities. We have two authors of this screening, Gulnara Svyatova, who introduced this perinatal screening, and thanks to which we can now show these figures, and we are not ashamed of these figures. These are very good indicators. And Rosa Suleimanova, who introduced the audiology screening, who invested a lot of her knowledge into this screening, and this screening is working. Next slide, please. If we talk about statistics, I will not talk a lot about it. The only thing I would like to say is that in Kazakhstan we have quite a number of children who require special educational conditions. They have special educational needs, and many children with disabilities. And all of them, for all of them, we must create conditions where they could function and which can lead to these children ending up in the society. So these are some data on prenatal screening. So what is prenatal screening? We are talking about 704 order on prenatal screening, and the roadmap became possible only because Arjan Sain initiated this roadmap. The first part of screening, the prenatal screening, if we look at it from 2007 to 2020, it covered it, it covered quite a number of women and even more children. Why there are more children? There are women who avoid screening. There are women who show up only for the child, for the delivery. And there is also another factor here, the responsibility of mothers. The neonatal screening back in 2007. Neonatal screening is screening of neonates in maternity hospitals back in 2007. Neonatal screening covered only 52% of neonates. In 2020, neonatal screening already covered 97.4% of neonates. And neonatal screening includes hypothyreosis, neonatal hypothyreosis screening. It includes hearing screening, and ophthalmology screening leaves a lot to be desired. So I'm not talking about ophthalmology screening. I focus only on prenatal and neonatal screening. And lethal developmental disorders, thanks to this screening, have reduced from 6 to 3 over 13 years. So this screening is effective. I'm showing you the roadmap, and in terms of what we are trying to implement, and the decision has been made on a pilot and introduction into the neonatal screening. The item 7, selective screening of neonates for hereditary metabolic disorders. We have broadened the list of hereditary metabolic diseases. In some countries it is 6. In some countries it is 8. In our country it is for phenylketonuria. So what are hereditary metabolic diseases? Science is advancing. In Kazakhstan, we have specialized equipment, and parents do not have to leave Kazakhstan to know what's happening with their child. And these hereditary metabolic diseases are manifested in about 80% of neonates. And what is interesting is behind autism, cerebral palsy, epilepsy, there can be signs of hereditary metabolic diseases. And now we have the issue about when we carried out research in 1,500 people, and this research showed that in Kazakhstan, it is the frequency 3.8 per 1,000 neonates. It's quite a representative figure. In selective screening, it grows to 30 in 1,000 1,000 children. Selective means that there are clear indications for the research, for this, for the analysis. For now, we don't have these diagnostics, and the working expert group uh, have introduced these uh, as item 7 in the roadmap, and this relates to the pilot to piloting research, to piloting selective screening in our in our maternity hospitals, just like we have for other diseases. I just wanted to show you the autistic masks of genetically mediated pathologies. On the one of the syndromes has been removed from autistic spectrum because they identify genes. The the Bell syndrome, for a long time it was called atypical autism, and now it has been verified that it is genetically caused. Next, it is Crab disease. The thing is that unfortunately not all hereditary metabolic diseases can be treated. There is no treatment for all of them, but there is quite a number of them which require only vitamins and right nutrition. For example, in phenylketonuria. So you need just products that increase phenylalanine. And among the indications are autistic children. Out of 1,500 children, in 8 children, we have the autistic clinics. These are children of community associations, which for many years have been considered as autistic, but we have identified Crab disease and other diseases in them, and now we have a new question for science. What is autism? Is it a comorbidity, or is it autistic syndrome in hereditary metabolic diseases? The same relates to cerebral palsy. These data are just being developed, so I cannot specifically address that. And so, as a result, we proposed to the Ministry of Health, we proposed this route of diagnosing hereditary metabolic diseases starting from the maternity hospital or starting from the clinic. For example, there is an autistic child which meets certain other criteria, and we can work on them. The screening of psychophysical development, which is also in the order, it is a separate topic because back in the day, Sutter developed a screening attestation, and it was in use until 2016. But later, this screening was removed, and they introduced a new one, and now the working group is working to get back the old screening or to work out another option that would be effective so that in the developmental office this physical screening would be more effective. Now, Rosa Ayjanovna says that terminology is very important. Next slide, please. And thank you for your attention. Thank you, Korlan Zarlikovna. So I'm not past my schedule. There is even more than 1 minute left. So it's our time. On behalf of the medical community, Gulnar Salavatovna, we have 1.5 minutes. I've known Rosa Ijanovna for exactly the amount of time that Sutter has been in existence. I've known Rosa Ijanovna for 25 years. I was a young pediatric psychiatrist. I came across a situation where we diagnose our children, and what do we do next? Do we treat them? No, they don't need treatment. They need correction and adaptation more than treatment. And there comes Sutter. So, Rosa Ajanovna, we wish you we wish you long years of productive work. And this is a notebook, an album for Rosa Ajanovna to not to write her memoirs, but for Rosa Ajanovna to write everything what she thinks and what she knows from her practical experience. And the inscription here says, lifelong profession. Thank you very much.
Dear participants, it's important to talk about a systemic approach to organizing early intervention, and there should be a clear route for children with various disabilities and integration between all the stakeholders. And about the system of early assistance and Russian Federation, we ask now to speak the Doctor of Pedagogical Sciences at the Institute of Correctional Pedagogy, Russian Academy of Education, City of Moscow, Razenkova Yulia. Please, you have 15 minutes. Thank you, colleagues, for the opportunity to once again tell you about what is going on in the Russian Federation in terms of the development of the early assistance program. Please, let's run the next slide. Over the past 30 years, the practice of early assistance in the Russian Federation is expanding and picking up pace. What has been done throughout the past 30 years? Let us now go over the main milestones so that it's clear. Starting 1992, the city program Habilitation of Babies has been developed and implemented in the city of St. Petersburg, which has become this main flagship to the development of the early assistance system in the Russian Federation. Further on, we've developed regional models of early assistance in education. That's starting from 1999. The first program, the first regional network program was developed in the Samara region, and currently the Samara region has a network of services on a professional level, and then starting 2004 until 2008, they've been creating that at a municipal level. The Republic of Mariel, which joined in 1997, in 2007, and also design an early assistance system. That's also the Omsk region, which started in 2015, and through today are developing the early assistance system. That's the Krasnoyarsk region, Novosibirsk, Yakutia. These are these projects that we've supported and worked together with the government authorities in designing these projects, training the specialists, prepare the allocation of resources for the early assistance systems. Experience has been accumulated in providing early assistance in individual, state, and municipal organizations, and a big contribution of that in the Russian Federation was done by the Fund for Supporting Children in Difficult Life Situations and other charitable organizations. And We've created the initial level of departmental regional models in healthcare. That's the route that was taken by the Republic of Tatarstan, the Altai Territory, Bashkortostan Republic, and certain other republics. And they were doing that, including with the support of the fund for supporting children in difficult life situations. Let's go to the next slide, please. We've accumulated experience based on socially oriented nonprofit organizations, parent organizations, foundations, and other NGOs. That's a great move forward throughout the 30 years. It's a movement that was born in Moscow and St. Petersburg, and it's a socially non-commercial large structure that furthers their experience and are creating all of these early assistance points in this non-governmental sector. We've accumulated experience of non-profit organizations in spreading their practice, and we've got results of scientific research which we obtained within the framework of the National School of Special Psychology and Special Pedagogy. We've developed scientific methodological support of the early assistance system. Miss Yulia, your internet seems to be breaking up because we can't hear you. Oh, my internet. When did you lose me? When couldn't you hear me? Just please continue. We understand, but it's just that it's falling off. We've obtained results of scientific research in their from the project of the Agency for Strategic Initiatives to promote new projects for 15 constituent entities of the Russian Federation on the basis of education departments and education infrastructure. And we've established early assistance services and built up an interagency cooperation mechanism of government and non-government services of early assistance. The results of the implementation of the early assistance system at once on the basis of the 3 departments within the framework of the Accessible Environment Program, that's the Sverdlovsk region and Perm territory. Models of early assistance were created as innovative in the framework of testing the mechanisms for implementing the concept for the development of early assistance in the Russian Federation for the period of up to 2020, which was approved by the Order of the Government of the Russian Federation number 1839, dated August 31, 2016. It also included a plan of implementation for that concept. Next slide, please. And so if we talk about this topic, then the stages of the formation of the early assistance system in the Russian Federation can be seen in these 3 steps. The first stage, 1992 through 2008, these are individual projects and experiments, both on the basis of state and non-state institutions in a number of regions. Second stage, 2009 through 2015, projects of early assistance services based on state and municipal institutions on social protection, healthcare, education, development of an early assistance system on the basis of socially oriented NCOs, parent organizations on the basis of commercial institutions and nonprofit institutions. And the third stage, it started in 2016, of course, from the moment of the approval of the concept of the development of early assistance. By the managing bodies, the government managing bodies of the Russian Federation. The next slide. I can tell you accurately only about the statistics that I have on hand right now. and that would have to do with the education ministry statistics because I work in that system. And the Ministry of Education, together with the Institute of Correctional Pedagogy, we hold annual monitorings. In 2020, the monitoring was we had 84 constituent entities of Russia took part in this monitoring, and we received the data. And for a lot of organizations, let's go to the next slide, please. As of 2020, there are 6,040 early assistance services in Russia. The Ministry of Education has planned that by 2024, there should be about 7,000 early assistance services in Russia in the education system. Now, 4,240 early assistance services operate on the basis of preschool education organizations. On the basis of general education organizations, we've opened almost 1,400 early correction services. Based on regional and municipal centers, we have 316 services, and 85 services were opened based on other organizations, additional education organizations, including centers of children's creativity, professional educational organizations, centers for orphans and children left without parental care. Let's go to the next slide, please. The total number of calls to early assistance amounted to 458,794 calls. And these numbers evidence a higher demand for these services, as well as the effectiveness of the information and educational work carried out with parents raising young children. Let's go to the next slide, please. Now, legal support to the system. Currently, we have only mentions of the system of early assistance alongside the preschool education system and the federal law on education in the Russian Federation. As of today, the Ministry of Education is preparing an addition to the federal law on education in the Russian Federation relating to the system of early assistance in education. And of course, if we're also talking about the concept for development, which is not a legal document. It is a strategic, I guess, political document, but it has played an important role in the development of the early assistance system in the Russian Federation. And of course, the action plan for the implementation of the concept, the first action plan we are finished with, it has finished, and we're currently working, three ministries, three agencies are working, including us, the voluntary desire of our founders of the Ministry of Education, to the development of the new plan of action until 2024 on the implementation of this concept of early assistance in the Russian Federation. And of course, today it is very right, we believe. We've approved a program of scientific research for Russia for the long term, where we discuss children with disabilities, and it has additions from scientific research. In the state program of the Russian Federation, the development of education, the launch of that program and its operation in the past years has impacted extremely strongly the development of the infrastructure of early assistance. the establishment of consultation centers and consultation outlets for parents of children with disabilities, including the consultation outlets and the consultation centers for working with families. We use those as platforms to develop also the system of early assistance. The next slide, please. I've already mentioned that currently the Ministry of Education of the Russian Federation has developed and submitted to the government a federal law and amendments to certain legislative acts of the Russian Federation in terms of ensuring the right to education of persons with disabilities, which clarifies the definition of early correctional assistance provided to the children with disorders of various nature. And these are exactly those changes that we have yet to discuss with the new staff of the Duma, which still has to be elected. Next up, how will the system of early assistance develop in the future? That every region should have a program or a draft or drafts included into the program of the development of the early assistance program for their region. And that is why these programs and projects or drafts every region should develop and are developing, and should be creating roadmaps. As of today, we're talking about the fact that in the Russian Federation, the early assistance system is being established as a system providing the variability of forms of organization of early assistance. And in each region, it will take into account the specifics of the development of each region. The 85 regions of Russia are not similar to each other, especially those regions that are Western, Central, and Eastern, and Siberia. Every constituent entity of the Federation is quite special, and as the early assistance service and its structure is included into the system of the already active system of healthcare or education or social protection, and of course, in each region, it's going to have its own, and it does have its own peculiarities or special characteristics. It is true that in terms of the events on the development of the early assistance program until 2024, we we're planning for new forms and also shifting away from institutional forms of early assistance, which are very characteristic of today's Russian Federation, shifting to a system of home visits of families, and the development of that line is considered major today. And of course, the central, most important trend of today is the development of centers of early assistance in rural areas and rural settlements and territories, as well as remote territories which are far away from regional centers. How will that be done? Via mobile brigades of early assistance. And these projects have already been tried in the Bologud region and in the Republic of Mariel, in the Samara region as well. When a family finds it very difficult to take their child to a regional center for early assistance, it is impossible to deploy early assistance because there is no infrastructure in the rural area that you could integrate it in. There is no kindergarten, there is no first aid facility. It is difficult, and that is why we developed these projects that have proven their great effectiveness in that direction. will, I hope, be picking up pace that is already planned for the next action plan. And that will allow us to carry out screening as well, actually. It's what we've been talking about for in the rural areas and in these remote locations. It is, of course, an expansion of psychological services in the early assistance system due to such innovative forms as urgent psychological assistance or a psychological ambulance, which can be deployed based on birthing facilities. And these analogies are already present in Russia, and they have proven their effectiveness. And now there is a way to scale them. And it also includes the development of the teaching expansion of teaching services in early assistance, including leveraging the social surrounding of the children, involving the peers of the child, and of course, the one of the resources will also be mutual assistance and mutual support of the families. When one family that has gone through the early assistance system supports the new family to come. That's based on American and Dutch systems where mothers help mothers and families help families. There's quite a bit of these examples developed today. That there are different technologies that parents have created themselves, which are working pretty well in the early assistance system. Thank you for listening. I'm thinking that you have been convinced that Russia is taking great leaps in developing early assistance. It's of course not as simple, and the most difficult is interagency and intersector cooperation. It is exactly that which we demand projects from and programs from, and of course, using digital platforms for information exchange and redirection the client from institution to institution, from system to system. Thank you very much, Yulia, for this really interesting information. It is truly very important to have a systemic approach to this, but to take into account the specifics of each region and to be proactive. And most importantly, of course, at the foundation of this should be research, scientific research, long-term research with specific recommendations for further actions. Dear participants, one of the key methods of screening is audiological screening of children. And different countries have their own approaches. And this year, at the initiative of Rosa Suleimanova and a group of surdologists headed by the head surdologist of the Ministry of Healthcare, we've made quality changes to the order to improve this type of screening. And right now, is our speaker ready from Germany? We are waiting for her to arrive shortly, so I suggest this format. The speaker will start on time, but I think we still have a few minutes, so I'm going to pass it to Rosa.
I would like to thank Yulia Anatolievna for this very detailed description of the trends that exist in the development of the early assistance system. As you understand, this system is very multifaceted based on the number of needs, on the types of needs. One of the needs is related to the remoteness of the child. Also, another need is the need for communication and the and the parents' interaction is also a very interesting form of assistance, and it also merits attention. Today there was a talk by Ludmila Golovchits on training specialists on preschool preschool specialists and the experience that Russia has. That, of course, is very fragmented. It's not at the federal level, it's not compulsory, but it is something that gives food for thought so that they can start working, start applying it on a broad basis. This conference will be recorded, and I would like specialists who deal with early age children. I'm referring to offices of correction, special preschool organizations, so they can think and maybe come into contact with the Russian colleagues to study their experience. And if you need any contacts, we're always ready to provide those. And I think that the Institute of Correctional Pedagogy can always provide recommendations and provide contacts of Russian specialists. And that's what I would like to focus your attention on, dear Kazakh colleagues, so that I'm talking about specialists, early intervention specialists. Unfortunately, the speaker is not on yet. Dear participants, previous speakers described national level projects, national policy level projects. We have here a person from the National Center for Developing Inclusive Education, Zauria Bolatovna. She will talk about organizing the system of early assistance to children with disabilities in the work of rehabilitation centers and the Office for Psychological and Pedagogical Correction. I would like to start my presentation with expressing gratitude to Rosa Ayjanovna. We are children, so to say, of Rosa Ayjanovna, and the model of early intervention back in the early 2000 was developed under the guidance of Rosa Ayjanovna. And the theoretical basis of early intervention system was developed in 2001. Rosa Ayjanovna published a monograph on correctional assistance. Rosa Ayjanovna, great thank you from your students. In my presentation, I would like to tell you how we continue the work of Rosa Ayjanovna with consideration of global and national trends. We all understand that early intervention in the global community is seen as the most effective solution of the issue related to the adaptation of children with disabilities. Many countries have early intervention models. Our educational system also has a model for early assistance to children, which is a set of corrective, pedagogical, psychological programs the system for early assistance, which lies at, in the basis of the offices for pedagogical and psychological correction, was developed by under the guidance of Rosa Ajanovna. I would like to focus on the fact that we have rehabilitation centers and psychological pedagogical correction offices, special education institutions that provide integrated medico social and pedagogical psychological assistance to children with disabilities. And on this slide, you can see a statistical map as on September 1, 2021, Kazakhstan has 14 rehabilitation centers and 2007 offices for psychological pedagogical correction, according to the regulatory documents. In particular, Order 66 on the activity of rehabilitation centers and office for correction. The priority area is children of early age. That's the priority for their activities. Next slide. And you can see now on the next slide, on this diagram, according to regional and city offices for correction on January 1, 2021, there were 5,641 early age children with special educational needs. At the same time, psychological and pedagogical support in the offices of psychological and pedagogical correction is being received by 2,440 children and 429 at rehabilitation centers. In the system of the state service for children with disabilities, we are now implementing social model. We are moving away from medical model to social model, and we focus on early detection of children with special education needs and on providing assistance to their families. The country has no services of early intervention. There is no properly developed system for early assistance. There are long lines for psychological assistance. In working with small children, our main goal is to normalize the life of children. In particular, create normal conditions of life for the children, normal conditions for the child development, and creating normal environment, normal community around the child. I would like to briefly speak about the rehabilitation centers and the pedagogical correction offices activities. First, their accessibility. The child should receive assistance not far from their domicile. For this, we have the regulatory basis in Kazakhstan, local ordinances, local orders, law on education, law on medical correctional support of children with disabilities, which guarantee a child this service within a walking distance. And this service is free of charge and funded by local budget. Next item is forming new conceptual approaches based on interdisciplinary approach. Satisfying special education needs requires the participation not of one specialist but of a team of specialists, an interdisciplinary team. So this is pedagogues and health specialists like physical training pedagogues, neuropathologists, pediatrician, logopedicians, logopedists, etc. So it's a large team that help the child to normalize their life, and the whole team participates in assessing special educational needs of the child. The next approach is to move towards interventions aimed at the child. They involve the engagement of family into the pedagogical process. This is when we are based not on the disorders of the child, but when we are based more on the strong sides, on the family's resources to provide assistance to the child, and the use of group formats with active engagement of parents. Activities are based on needs and wishes and of the child and the family. The task is not to form a certain skill in the child, but to help develop parents' competency in teaching the skill. And the next is start using functional classification. I'm talking about the ICF. In ICF is a functional classification, is more of a social classification where focus is made on the child's activity in the family, in the community, and it provides for engaging parents, for drawing on the strong sides and favorable conditions for involving parents. The availability of different programs. Today, we cannot say that in the rehabilitation center and in the correctional offices there is a variety of programs. However, our children and our families can receive a certain range of services. On this slide, you can see what programs and services are available in the rehabilitation centers and correctional offices, starting with assessment of psychosocial issues of the child, development of individualized program for helping the family, special pedagogue activities, logopedicians assistance, group and subgroup activities, the services of the social pedagogues, selection of technical equipment, massage, physical procedures, developmental programs for children with disabilities, including for children with the Down syndrome, hearing impaired children, special developmental programs for autistic children, which was developed in 2020, and program for sensomotor development. Subsequently, I would like to focus on the assessment of psychosocial needs of a child and development of a program for family assistance based on ICF. The assessment of the child's needs based on ICF in the correctional office and rehabilitation center was developed by student of Rosa Ayjanovna, who heads a laboratory for inclusive education. And this program includes several stages. The first stage is the primary meeting with parents. At this meeting, the specialists identify what identify the problem, the the peculiarities of psychosocial development of the child, and the environment. At this stage, specialists of the Rehabilitation Center and Correctional Office use different tools, and one of the tools that we propose for to parents is the Kazakh version of KID scale and CDI scale. These scales were also developed jointly and under guidance by Rosa Ayjanovna, by a specialist by the name of Jalmuhamedova. The second stage is the examination of child and discussion of the examination results with parents. At this stage, specialist examines the child on main development areas described in ICF: acquisition of knowledge, mobility, communication, self-care, interpersonal interaction, game. We know that preschool children developed by game, and game is one of the main resources in the child's life. Problems in the child's life, determining favorable and adverse factors in the child's development, and all of this happens in discussion with children, parents, and it is at this stage that they come up with the hierarchy of requests from demands from parents that parents would like to be resolved by the rehabilitation center. The third stage is the team assessment of the child's development based on ICF, and multidisciplinary team consisting of a neuropathologist who assesses the child's state of health for different structures and systems of the body: skeletal, muscular, motoric systems. The pedagogues, defectologists, treatment, physical culture, they assess the child in their respective areas. And the assessment is as follows. So they assessed what can a child do. For example, in terms of a game, what game is the most motivating for the child and most interesting for the child? What problems are there in each area? What are the deficits? What are the challenges in each area? What are the barriers in each area of development? And what are the resources of the family to develop the child's activity? So how can we use the family's resources to assist the child? This assessment is basis for an individualized development program, which takes into account the demand and requirements of the family. We have here the structure of the home programs, which consist of long-term goals, short-term tasks, and how we are going to do it, and what resources of the family and organizations we are going to use, and who exactly is going to be involved. And the next slide shows the program. Can you show the next slide, please? This is the individual program for child assistance. This program was developed by a multidisciplinary team of specialists from our center. The child is child A, age 2.9 years old, and the first requirement of parents is to help child hold their head and to eat with their hand. And so steady holding of the head is the task. So, and our subtasks is to strengthen the neck muscles. And we identify tasks for each participant, and we also identify what the mother does. Next slide, please. You can see that there are three goals according to the parents' requirements or the parents' demand. This is the program for assistant, which is implemented at home. In parallel, we develop a program for specialists. It is identical to the home program, and the specialist program is working within an organization and implementing the program at home. And so I would like to focus on group assistance, where children are taught by parents, and teaching is provided in an environment that is maximally similar to real conditions. And we have two goals here. The first goal is to enhance parents' competencies, and second is to assist child's development. And in the group work, the experience of a specialist is aimed not at lecturing parents or at correcting the child's disorders, but first of all to support the family, at supporting the family. That's a kind of indirect teaching of the child. And the task is to guide parents based on their real day-to-day situations. Next slide, please. Group activity programs are built in a way to have the child and parent act as partners and be equal, because in group work there is a certain structure that we will address subsequently, but all of it takes into account the child's peculiarities. If the child cannot, at a certain moment, work with a certain situation, in a certain situation, or the parents have no resources, then the specialist provides support to the parents, and parents can take a break, and we continue working this. I have mentioned assessment, identifying activities of the child and their strengths. Here we meant that what the child can do, and these activities should be used during the group tasks. I have also said that we do not aim at shaping a specific skill. The most important thing here is to help the mother or help the parents. And the focus is to help the child build on existing skills. Here we can see the structure of an activity for group format. We have the greeting portion, where children sit around in a circle with parents, and we use different forms of work with children. We use different communication systems because children are different. There are non-speaking children, and we use alternative communication systems for them, and other systems that help engaging children in this communication process. Musical and motoric activities, cognitive block, game block, non-structural material block, didactic games, tea drinking as an opportunity provides great tea drinking provides great opportunity for children to learn from each other. Children can also relax and talk to each other, and as a form of experience exchange and child's development. We had cases when a pedagogue teaches a child how to how to take tea, how to eat, but during a tea drinking activity, this is a kind of practical experience. and of course, uh, dance with the mother and the goodbye ritual. That this is the structure. This slide shows the algorithm for pedagogical and psychological support. We divided children into categories. We identified forms of assistance and frequencies and main areas. And you can see that for younger children from 0 to 1 years of age, we provide consultative activities at rehabilitation centers, and the main areas starting from assessment of special education needs through to development of program and providing consulting and other services. Even though early assistance is a priority for a rehabilitation center or correctional office, at present there exist quite a lot of outstanding issues that impede the impede early assistance. These problems include, first of all, insufficient network of rehabilitation centers and correctional offices. There are many children. You have seen diagrams, and diagrams show how many children there are. Children, children fail to receive assistance in the correct age, lack of supervision, when which where young specialists are given support, lack of regulations, lack of professional standards for early assistance, significant difference in early assistance between different regions and organizations. I have described the rehabilitation centers system, but this system continues to be implemented. In Almaty, this system may be operational, in Nur-Sultan as well, but in some of the regions, this system might not be operational. So we are working to provide a unified operation of the system throughout the country. The rehabilitation centers are aimed at are correcting mental and physical defects, interaction with databases of the social protection. So, insufficient material base and very serious cause that leads to that is a barrier to early assistance is the lack of normative documents that would determine the norms of loads of the working load of teachers. So there is a number of problems here. The analysis of rehabilitation centers' activities, organizing assistance in the first years of their life in our country allows us to make draw the following conclusions. May you show the last slide? We need to broaden the network of the correctional offices and rehabilitation centers to make early assistance services more available to the maximum number of children. Prevention of secondary disorders and issues. We need to use a unified approach in early assistance to children and families based on educational needs determined with consideration of ICF, we need single legal space and standards. We need standards on early assistance. We need amendments to the regulations that govern the work of rehabilitation centers and correctional offices. We also need a resource center that would enhance interdepartmental cooperation. And we also need to come up with a regulation on intersectoral cooperation in the interests of the family and the child. Thank you very much. This is very relevant topic. From the very start of the child's life, uh, children's family encounter many problems, mostly mother, and it is parents who require psychological support and recommendations.
Candidate of Pedagogical Sciences, the of the Federal State Institute of Correctional Pedagogics, City of Moscow, Galina Odinakova. Galina will speak about the behavioral difficulties in young children with Down syndrome when interacting with their mother. Please, Ms. Galina. I wanted to say that this is a joint presentation with Ivanova Maria, the research associate of the Laboratory of Comprehensive Research and Early Assistance of the Institute of Correctional Science. And I just wanted to say that in this session, we included working with the family. We had to include working with the family in this one because that's the most important part. And success really depends on how the family participates in the development of the child. So please. This joint presentation in Ms. Limanova, me and Galina. We congratulate you on your anniversary. Good health to you. We wish the Sauter Center to blossom, and I thank the organizers of the conference for the ability to speak. I'm Marina Ivanova. I'm a research associate at the Laboratory of Comprehensive Research. And the topic for my presentation is behavioral difficulties in young children with Down syndrome when interacting with their mother. So just a second now. Here it is now. Can you see my presentation? Yes, we can. And we can hear you. Thank you very much for your feedback. And what's important to say is that issues with behavior with children with Down syndrome, they begin to manifest themselves in preschool age. But their early signals are found already at the age of 2 to 3 years. And according to foreign researchers, about a third of children with Down syndrome at an early age show already signs of a difficult character. That's written about Deborah Fiedler and Sue Buckley. And we're talking about a whole complex of behavioral difficulties such as stubbornness, outbursts of irritability and anger, stereotyped actions, and such behavior at an early age can be an early signal of future behavioral problems in the future during preschool and the school age, and may seriously interfere with the development and learning of children with Down syndrome. And the Institute of Correctional Pedagogy of the Regional Academy of Education planned and conducted a study of interaction in mother-child pairs as part of the pedagogical approach to preventing and overcoming difficulties in the development of communication in infants, in young children with disabilities, and close adults. And the supervisor for this study is the Doctor of Pedagogical Sciences, Zinkova Yulia. And see, the study that we've conducted covered children with various impairments, blind children with organic lesions of the central nervous system, with a genetic disorder. And I'm going to tell you about the research that was done in the laboratory. And 27 mother-child pairs participated, so groups with the Down syndrome, and 18 groups without developmental disabilities, also mother-child. And the age of children is the second and third years of life. Now, in our work, we used analysis of video materials of interaction between a close adult and a young child with disabilities. What exactly that was. So firstly, the procedure for collecting, processing, and analyzing interaction using video capturing. Now, filming it on video took place in a room familiar to the child, which is important. The researcher was familiar, so it wasn't their first encounter. The mother was asked to socialize and play with the child as they usually do at home in their normal everyday situation. And afterwards, general for all categories of children and close adults, a qualification grid is noted, and a system of parameters for assessing spatial and temporal, procedural, and content characteristics of communication. And all right, right, sorry. And the next thing I wanted to mention was that the identified phenomena of communication between the mother and the child, such as the child repeatedly is proactive in communicating with the mother. That was one phenomenon. Another phenomenon could be, for instance, that the child's answers contain contradictions. So it's kind of the child wants to go ahead, but then they refuse at the same time. So both yes and no. So it's ambivalence in a way in their behavior. And if we talk about the phenomena of the mother, what we can say about that, for instance, the mother voices the child's external world, or the mother tells or says that she does not understand the child. And in total, there's about 37 of these phenomena about the child, the good, favorable ones, the unfavorable ones, about the mother, both unfavorable and favorable ones. And these are, this research was very interesting, and interesting conclusions can be drawn. And further in the presentation, we're going to have a list of literature where you can get acquainted with all that in detail. But on this slide here, you can see the first page of the phenomena registration protocol. And here you can see in two columns the favorable and then unfavorable ways of communication. The first phenomena that you see, the 9 lines, are about the mother. The favorable, her favorable manifestations or her actions, and the unfavorable ones. And there's, for instance, we are registering in this protocol yes or no. We tick boxes and then we keep working with these phenomena. And I just like to say the following thing that I can say is that these phenomena have been described in children with Down syndrome, which these phenomena we attribute to behavioral difficulties. So, what could be said here? Just a second now. For example, refusal to communicate with the mother, accompanied by protesting behavior. It may be aggressive manifestations directed at the mother, at oneself, at toys, ways of switching the mother's attention, which are sometimes dangerous. For example, a child sitting in the mother's arms and leans back swiftly, a field behavior, when fascination with the surrounding sensory field is higher, when the adult is not significant and is nothing but a part of this field. Contradictory messages, so when the child's remark simultaneously contains agreement and denial. Stereotypes, when a child gets stuck on monotonous uniform actions or actions with a toy. Correlation analysis showed that these manifestations of difficult and uncomfortable behavior are found together with communication problems. And the child rarely or never turns to the mother with a request. More often than not, does not respond to the mother's questions or proposals. The child has a small number of means of communication. And altogether, this is observed with an unfavorable version in the development of communication. And I'd like to announce briefly that currently, together with Ms. Galina Yurievna, we are studying in depth these behavioral difficulties, these manifestations, and these protests, and the stereotypical behavior, the field behavior. And we're preparing this big compendium, a methodological guidebook, where we will be specifically talking about young children and preschool children, so infants and young and preschool children, how these phenomena intersect and what are the new things that arise in school age. So you can find that on our website later. Now, the variants of communication developed in pairs of mother-child with Down syndrome, favorable about 45%, unfavorable about 55%. And all children that participated in the research received psychological and pedagogical assistance based on the fund down, side up. And they got assistance pretty much since birth. And we could suppose that amongst the mother-child pairs that have not been covered before, the unfavorable ones, there could be a lot more. So in a child with an unfavorable variant of interaction with the mother, what we can generally see, there are behavioral difficulties. There is a level of retardation in psychomotoric development. Passivity is seen in communication. The child plays by themselves, does not invite the mother to play, may not even respond to the mother's proposals, may refuse to communicate. Perhaps it will be a dialogue that doesn't develop. So a child might approach their parents, give a toy, and leave. So there is an initiative, but then it's being closed down. Now, with the mothers, what we can see with an unfavorable version of interaction, firstly, they do not play together, but just observe the child's game and give speech instructions. How does that look like? Put the plate on the table, take the teddy bear, and recommendations like that. are just of instructive nature, and these direct instructions in the game, they take a toll on the behavioral reactions of the child in preschool age. And I was actually dealing in that very closely. Now, what else I can say is that mothers do not understand the child, and they often say, "What do you want? I don't understand you. You probably are in a bad mood," or interpretations like that. And mothers may criticize the child sometimes. It sounds like, "Oh, you're being lazy," or "Oh, how lazy you are today." They can also um, talk about that the child is unwilling to communicate. They can insist on their own agenda and not support the child's initiatives. They can give inadequate tasks or be overly strict to the child's answers, or criticize whether something is right or wrong. If a child picks up a red ball, for example, and it's going to be like an apple, and then the mom will say, "No, the apple is never of that color, so it's only that." Another object. So these critical remarks they can give to the child, speaking negatively about the child or their character, that can happen too, with an unfavorable version of interaction, I reiterate. With a favorable version of interaction, what we can see with the children, they have no or have minimal behavioral difficulties. So pretty much using their speech, you can negotiate with the children. They pretty much do not demonstrate protest. The level of retardation and psychomotor development of children is less deep. Children are active in communication. They prefer to play with their mother, and most often they respond to the mother, respond to her initiatives, and there are no cases of refusal of the child to communicate. So the child will any way react to the initiative of the mother. Now, what we're seeing with the mother, with a favorable version of interaction, the mothers play with the child. They bring variety to the game, and they get down on the carpet with the child and they play on one level. It's a wonderful game when both the mother and the child are in one field of vision, kind of, and they use the same means of communication, understandable both to the child and to the mother. And mothers support the child's proposals about the game. They support even approximate answers, and they talk about the character of the child without assessment. They often praise more often than not, and they call the child what caught their attention. So they notice the slightest change, they notice where the child is looking, and they comment on that. And of course, there's no criticism or misunderstanding. What else I wanted to mention was that a connection was found that in the case of a successful interaction, the child has no difficulty in communication and no difficulty with behavior, and mothers understand well the child. They know how to negotiate with the child, and they can create conditions for the child's active participation in this dialogue, and they support the child as an individual. It's just an amazing dialogue to observe. A connection was found in case of an unfavorable interaction. So with a child, they have difficulties in communication and behavior. The mother does not support the child's activity and dialogue. They criticize the child's actions, or they depreciate the child's individuality. Moving on, I'd like to say behavioral difficulties accompany a disorder in the interaction of a mother and a child with Down syndrome. And children have a need for communicating with the adult, but it has its certain limitations, that need. And the mother does not support the child's activity in communication. And in this case, it is necessary to work both with the child and with the mother. and then it is so that Galina works more with the early age children, and then the preschool children. Following the same system, I work with the preschool age children, and of course, there you have some fabulous, amazing results and observations. Now, it's also important to say that the pedagogical work is based on technologies for preventing and overcoming difficulties in the development of communication in young children with disabilities, authored by Razenkova Yulia. The purpose of the correctional and pedagogical work is to create conditions for the development of the child's communicative need, to teach the mother and the child communicative skills. The main provisions of the complex of correctional and pedagogical measures, what they are. Firstly, it's the development of motives for communication. It's important that the child want to communicate with the mother and to urge the mother to communicate. It's important that the mother be motivated to communicate with the child. So work is carried out both with the child and with the mother. So three people are present: the specialist, the mother, and the child. If sometimes if it's not the mother, it's some other close adult relative, the closest contact with the child. Then reliance on substantive activity with the involvement of resources of emotional and personal communication. And work is built according to always an individual program. For young children with Down syndrome, a technology for preventing and overcoming difficulties in communication and interaction of a pair of mother early child with Down syndrome has been developed as a way to overcome difficulties in the child's behavior. And this technology is also authored by Galina Odinakova. The technology for teaching children game interaction for the pair of a mother-child, child of preschool age with Down syndrome, as a way to overcome difficulties in the child's behavior through establishment of communication in a pair. That technology is authored by me, Marina Ivanova. And if special work is not being carried out, then these difficulties in this early age, the difficulties in the behavior in preschool, are then reinforced. And that is shown by our research and our multiple observations. And you can read about that in our articles. For children of preschool age with Down syndrome, you see on your screen right now on the slide this work. It is not completely put together yet, but there are some articles, and I'm going to show them to you. So take a look at this. This is recommended literature for this topic. It is present in printed version. It is present electronically. You can always read about it if you feel curious. And look, I chose these exact pictures. On the first picture, it's an unfavorable version. When the dialogue is broken up, the child may go into stereotypical activities, spinning bottle caps, turn away, the mother can break contact. And what a wonderful picture, and what emotion you see on the second picture. Look at the mother and look at the child. Emails, we will definitely respond. Thank you very much. Thank you very much, Galina and Marina, for this presentation. I'd like to say that other categories of children with special needs have needs for communication, and in support of parents is very important, and the active participation of a specialist is important. Dear conference participants, I'd like to present to you the next speaker from Germany, from Münster, the director of ped audiology, Catherine Neumann. She's going to talk about newborn hearing screening benefits for children in a global scale. Please, Catherine, you have 20 minutes.
Na, na,
She is currently at this European Congress that they're holding for audiology. She was warning us about that. She warned us about that. Now, I wanted to speak out.
On the previous, I would like to speak to the previous presentation, the communication issues, the interaction and recommendations that you provided in your presentation. They are in principle relevant for all, for the norm typical and for children with various disorders, developmental disorders. Therefore, I think your methodological recommendations are very important, and I think that correctional offices and rehabilitation centers and pedagogical institutions who train preschool teachers, they could make use of your methodology because the parent-child relationship is the basis of the whole process, not of the development correction process, but of the whole process of interaction between parents and children. So I thank you very much for this very informative research and for your presentation of their results, of its result, and the child-parent relationships is a very important component. For example, in a conference or in a round table, or it that relates to the preschool education as a whole. So what's happening there? So are they asking to be authorized, or what? We apologize. The next presenter cannot log into the system. We're waiting for Catherine Neumann. We are waiting for a presentation by Catherine Neumann, Director of Child Audiology in Münster, Germany. Catherine Neumann is the Director of Department for Child Audiology, Pediatric Audiology in Münster, Germany. I mentioned before that Rosa Ayjanovna and a group of surdologists made significant changes to the order, and these changes were related to audiology screening, and it would be interesting to hear how Germany works on it. They will address the how audiology screening happens not only in Germany but throughout the world. I would like to note that in Germany I became an initiator. They created tracking center, a center for tracking how audiology screening takes place in Germany and how children are referred by maternity hospitals to children's clinics or primary health care institutions, and how they track timely referrals of children for further interventions, including prescription of hearing aids. The tracking center works closely with various municipal services, and when parents do not have their children examined in a timely manner, social services come into play. So now that we are resolving our technical issues, let's, in the meanwhile, discuss the discussion questions, how the important components of the early assistance system should be developed. Or maybe the participants of this conference have questions. So please let us take those questions. And question number 2, the problems and development paths for screening of young age children. And question 3, what should we undertake to have screening as a steady state system? And of course, what do we need to do for the early assistance service? And maybe someone would like to speak, dear presenters, dear participants, and dear audience. You're welcome. And Gulzia Kaybaevna, I think that it would be interesting to hear the audience and participants in this conference. And I'm summarizing this session, and there are a number of proposals on my part. Those related to policy on early assistance. But maybe there are proposals from those who are online. May I exchange my experience, share my experience? Can you hear me? You cannot see me, but that's okay. This is a very interesting problem. And I like how Mrs. Razumkova said there are lots of early assistance services, but in Tashkent we are still piloting 3 clinics in Namangan, Andijan, and Bukhara, and we are opening the office of early intervention. And now the Ministry of Education developed a resolution. So it's not early intervention now, it's early assistance. But what I would like to say, what the problem is in the healthcare, on the pedagogical side, we organized offices, we developed 4 or 5 aids on early intervention in Uzbek, but the Ministry of Health does not provide budget for neuropathologists or for pediatricians. I think our problem is like this. Can you hear me? This is exactly what we were discussing with Rosa Ayjanovna. We have similar problems, and even though for 2 years now we have been saying that the Ministry of Health should provide prompt and effective solutions, and I also said in my presentation that the child ends up not in the system of education but in the system of health, and early interventions should be very clearly built, and there should be a clear route. And then it is later than that education is involved, and the system of education has its own route. We have follow-up catamnestic services, and we even have catamnestic offices, but we don't have the specialists, and we have a similar problem as you do. I just wanted to share our experience. In our Republican Center for Social Adaptation, we provide early assistance. The sensory offices, the Montessori offices, rooms, parent clubs, art therapy clubs. We have a room for speech pathologies. We also opened early psychological intervention office, but this is a very short-term course, and due to the pandemic we have had to shorten it. But we need to do it at the national level so that each family clinic should have such rooms or offices, and this would mean preventing disabilities, and this would also be preparation for inclusive education. Thank you. Now we have Ms. Katrin Neumann on. Ms. Katrin, the floor is yours.
Yes, hello. I'm glad that I'm here. Thank you for the invitation. I share my screen. Okay. And give me 1 minute. Okay. Dear ladies and gentlemen, hearing loss is steadily increasing in prevalence. It is nowadays about 500 million of people in the world who suffer from hearing loss. However, the number is linearly increasing. The main reason is the aging of the population and the growth of the population. It is and remains an underestimated health problem in population medicine because it's the hidden disease. You don't see it. It has unfortunately still a low priority and inadequate resource allocation, and we need to make politicians and the public aware of it. Among the people who are hard of hearing are 7.3% of children. For children, we have the opportunity to prevent hearing loss. Most of childhood hearing loss is preventable, about 60%, because of infections. You can prevent infections such as cytomegalovirus infection. You can make a better care for mother and child, in particular of preterm children. You can avoid ototoxic medications in the newborn phase and so on. And you can prevent better in low resource countries than in industrial countries. Do you hear me well? Okay.
Yes, yes.
So, okay.
Good.
Un or undertreated hearing loss imposes a significant burden on individuals, especially when it starts early in life. Permanent childhood hearing loss is associated with deficits in language, cognitive, psychosocial, and academic development, as we all know, with negative consequences for employment and earnings. But there's ample short and long-term evidence from large-scale population-based longitudinal studies that newborn and infant hearing screening, in particular, if performed universally for all newborns, significantly reduces age of diagnosis and intervention, and improves all these items like language, cognition, academic, and professional outcome. If they get early treatment. For example, an Australian long-term study showed that the earlier intervention starts, the better language and functional outcome is for persons who wear hearing aids or cochlear implants. Or a UK study showed that teenagers who have undergone a hearing screening are better than those who had not later on. Also, the cost effectiveness of newborn hearing screening has been demonstrated. So we know for low income countries, prevention is the most effective strategy. And for high income countries, universal newborn hearing screening, which covers all newborns in a country or region, is the leading opportunity. A joint committee on infant hearing from the United States showed that the 136 guidelines, that means babies should get hearing screening at age of 1 month, diagnostics until age of 3 months, and therapy start at age of 6 months, should be regulated down if a hearing screening is universal in a country. The new goal is hearing screening by 1 month of age, audiological diagnosis by 2 months, and intervention before 3 months of age, which is ambitious. Okay. Already in 1995, a WHO resolution has been adopted that urged member states to prepare national plans for the prevention and control of major causes of avoidable hearing loss and for early detection of hearing loss in babies, toddlers, and children. Yet, in 2012, only 32 countries in the world had reported the implementation of such policies. And the WHO deplored a scarcity of epidemiological and other data regarding ear and hearing care. A second WHO resolution adopted in 2017 reaffirmed the aims of the first and called on member states to collect high quality population based data on hearing loss and ear diseases, because this was really lacking. Okay, in response to this resolution, the WHO released the first World Report on Hearing in March 21. This report summarizes epidemiological and financial data on hearing loss worldwide and proposes cost-effective solutions for ear and hearing care. It recognized the newborn hearing screening, NHS, as playing a key role by identifying the average coverage of newborn hearing screening services within the population. That means how high is the proportion of infants with hearing loss who has received appropriate intervention before the 6th month of life. This is one of the 3 tracer indicators in the world for global surveillance and monitoring of progress in ear and hearing care, one of the 3. The World Report on Hearing also references a survey on the global status of newborn and infant hearing screening. We included infants up to the age of 1 year that my team and I have performed, which is consistent with the goals of the WHO resolution and to serve as baseline for further improvement of newborn hearing screening effectiveness and data collection. This survey also includes data from Kazakhstan. Here you see it. It has been published and is freely downloadable. The survey asks for the proportion of children who underwent a hearing screening in the country, the screening methods, otoacoustic emissions or automated auditory brainstem response, which is AABR, or a 2-stage OIE AABR screening, first OIE, and if babies failed, then following subsequent AABR screening, questionnaire-based screenings, and others. It asked for the proportion of newborns who had needed diagnostics and those who had undergone it, the prevalence of childhood hearing loss, mean ages and median ages of age of diagnosis and intervention start, whom and for screened and non-screened babies, if there is a governmental mandate for the screening, where the screening has been done and who performed it, and which institutions performed the screening. Okay, here we have the results. We got questionnaires from 158 countries. This survey provides the first database in the world about the global status of newborn hearing screening programs. The reference period was 2009 to 2019, and it showed that 38% of the world's population had no or minimal screening, more than 1/3. And 33, another third, had fully or near fully implemented programs of more than 85% of coverage of the whole country or region with the hearing screening. OIE is the most frequently used screening method in 57% of countries, followed by 2-step OIE AABR screening, 30%, and 11% AABR screening. The average failure rate of the screenings was about 5%, which is not bad, but you see there's a large range from 0.2 to 31% failure rate. This failure rate was significantly lower in countries with high NHS coverage, and the range was narrower compared to countries with lower screening coverage. The mean loss to follow-up rate of babies who failed the screenings but never were referred or showed up for diagnostics is 17.2%, which is quite too high. Okay, here you see the coverage of newborn hearing screening programs. Dark green is 85 to 100% screening, and I got data from Kazakhstan that it is the case in Kazakhstan as well. I hope that's the truth. 50 to 84% is light green, China, for example, or Canada. Red is 0 to 1% screening, and gray is where no data are available. So here you see mainly the prevailing screening methods, the predominantly used screening methods. And for Kazakhstan, it has written OAE. The dark blue is OAE AABR, and the light blue is prevailing AABR screening. The average age at diagnosis of a hearing loss of screened children was 4.6 months, and that one of non-screened children nearly 35 months. The average start of intervention for the screened children was 6.9 months, and that one of non-screened children 35.2 months. And you see the big difference between both. Thus, the hearing screening is associated with lower average ages at which a hearing loss is diagnosed and treated at a time when the brain structures are still well physiological accessible for the treatment. Newborn hearing screening is performed mostly in birthing facilities, less in outpatient clinics or homes. Although governmental mandates seem to be associated with screening coverage, was a high correlation, there are exceptions. Of the 38 high coverage countries, 9 had no mandate. So it doesn't seem to be necessary absolutely. So here you see the prevalences of childhood of newborn hearing loss. It is in median 1.2 per thousand infants, and the range is from 0.3 to 15 per thousand. These findings are close to a recent systematic review, meta-analysis, and the highest prevalences were in regions where high proportions of inherited hearing loss due to parental consanguinity has been demonstrated, such as in Pakistan, Egypt, Algeria, Jordan, Turkey. In Pakistan, it was up to 15 per thousand. So parental consanguinity is an issue. The screening coverage was closely associated with average living standards and economic well-being, as measured by the average nominal gross product, domestic gross product per capita, GDP. The living standard in countries with full or near full screening is on average 10 times higher than that in countries with a screening coverage less than 10%. And the GDP correlated negatively with the fail rate, prevalence, mean age at diagnosis for screened and non-screened hearing impaired children, and the mean age at treatment start for screened and non-screened babies. So the coverage of screening is bimodally distributed. As you see, we have the low-income countries on the left side, which have hardly any screening and clustered together there. And we have on the right side the high coverage rate of the full implemented hearing screening. But here, the gross domestic product is shows large variance and include countries with a GDP less than 10, such as Belarus, China, Kazakhstan, Marshall Islands, Micronesia, Russia. The lack of regional or national newborn hearing screening databases and regular data collection impacts the quality of many screening programs. Such a lack is associated with a dearth of tracking programs to refer babies who have failed the screening to audiological diagnostic and treatment services. Without a tracking, the loss to follow up rate is usually high or simply unknown. That means we do not know how many children have failed a screening but never went to a diagnostic and treatment service. It was on average 7% lower in countries with low coverage than with high coverage. Without a database, information is lacking about how comprehensive a hearing screening program is. Reports on hospital-based data may or may be not uh, representative of an entire country. So the summary is, there are growing prevalences of hearing loss, which calls for action, including the implementation and improvement of newborn hearing screening programs. Resource allocation for these programs is needed. For example, you need screening centers, such as the SATRA Center. Governments should enact legislation to formalize the operation of hearing screening programs. The programs should be monitored through a national committee on ear and hearing care. There needs to be a clear definition of target parameters. That means how long do you speak from a screening, when it is a follow-up, what belongs to follow-up diagnostics, and so on. The accessibility of pediatric audiological services and rehabilitation program is a problem in many countries. Data collection and tracking systems should be established from the beginning of newborn hearing screening program implementation to track babies who have failed or missed the screening and to provide systematic information on screening coverage and quality, on intervention and rehabilitation services for children and families. You need a bidirectional data flow between the screening devices in the hospitals and the screening center and back. You should use in a country like Kazakhstan telemedical tools where the connectivity is available. You need an opportunity for case discussions in professional excellence circle with boards of experts. And I often get, or sometimes get, um, questions from Alina, from Mrs. Galieva, who asked me, Professor, how should I evaluate this ABR curve also? There are creative and affordable solutions for making hearing technology more widely available. Not Alina, Aijan, including bulk purchases. That means government purchases a certain amount of hearing aids or cochlear implants, which makes it cheaper. And my last slide, newborn hearing screening followed by early intervention has been shown to be effective, cost efficient, and an excellent investment of resources. It should be a part of national programs for ear and hearing care. Mindful of this tracer indicator defined in the World Report on Hearing. The World Report calls for a 20% increase in effective newborn hearing screening coverage by 2030 as one of the targets for scaling up ear and hearing care services. Our survey confirmed for the first time worldwide that newborn hearing screening benefits children, but that global disparities remain. But as the world moves toward achieving the 2015 Sustainable Development Goals and universal health coverage for everybody, it is important that needs of children with hearing loss are addressed and no one is left behind. I thank you very much for your attention. And here's our team at the WHO, where we worked on the World Report on Hearing. Thank you so much.
Thank you very much.
Thank you very much.
interesting presentation. Уважаемые
Dear participants, dear colleagues, if you have questions or discussions or questions on this current session, you're welcome to ask them. Dear Catherine, thank you very much for your presentation, for supporting our conference, and I would your suggestions that you made now, we will include them into the resolution, into the final resolution of our conference. And now we have an order, a big general order on screening that includes audiology screening. And of course, some of the figures that are shown that about 50% of children being covered by screening. I don't believe those figures, but we also conducted a research activity, and it demonstrated that these screenings in maternity hospitals and primary health care institutions, these are conducted as part of other activities. And head physicians, they account, they do their accounting not based on separate services, but on the bulk of services. So be it, a psychophysical screening or audiology screening. So therefore, thank you very, very much for your presentation, and we will include your suggestions in our resolution. And now we put this question on the tracking center into the roadmap, and the roadmap was approved by the Prime Minister of our country, and we do hope that the Ministry of Health will come with a certain decision on the organization of a tracking center that will monitor, that will track the screening, the audiology screenings, and that will track assistance rendered to children of preschool and school age. Thank you very much, Catherine. And now, summarizing our session, I would like to say that today we heard very informative talks which showed what areas should develop in terms of early assistance, starting from screening examination and ending with the corrective training. And in this respect, I would like to note the presentation by Zauria Jangildinova, who, as it were, provide basis for a normative act, for a regulatory document on norms, what should be the load, etc., and at the same time on the content and on the content of the early age children work, where a lot of attention is paid to the family. And also, I would like to thank Ms. Rozinkova for her shared experience of the Russian Federation. Of course, Russia is a very large country, and each constituent entity has its own experience, etc. So I think, I hope that you will provide your articles for us to include it into the collection of papers of this conference, so we can study the experience of your colleagues, and so we can better develop our national system. Before we finish today, I would like to carry my work to the end. I asked you to consider the questions for discussion, and I made a summary on all the presentations, and I selected some systemic things because it is the easiest for me to do. Of course, we have heard very high-class specialists and many things. So, a lot of material should provide basis for methodological and regulatory documents, but we should voice such proposals and recommendations. One of them is to make changes to the law on correction. We should identify the ministry that would coordinate programs for all such children. I think this is the most important that we should do in the first place, so that we should provide the foundation. Provide scientific research on a constant basis on improvement of early interventions. Determine a center for methodological guidance. So a center like this would provide guidance, methodological guidance, and provide methodologies for different organizations for interaction between each other. Screening systems require further improvement with integration of systems both within sectors and between sectors. We need to also provide funding. We should organize early assistance services. We need to build the organization of early assistance. We need to work out all the steps in the early assistance system. We need to work on selecting equipment for children with disabilities. We need to integrate psychologists into the family activities with a child. Dear participants, thank you for your work. Very informative presentations from speakers, including from foreign countries, from Germany, from Russia, from Uzbekistan, and I wish everybody good health. And I hope that all recommendations and resolutions of our conference will reach decision makers, and those decision makers will take the right decisions. And I hope that we will build good interaction between different sectors on early assistance. Dear participants, the first day of our conference is over. Tomorrow, we will continue our work. This will be 2 sections: assessing needs of children with disabilities as a basis for corrective support of children with disabilities. We start at 10:30 tomorrow. And also please note that the conference room will be open at 9 o'clock. The virtual conference room will be open at 9 o'clock, so there are no authorization issues. So please, let's start tomorrow. Let's start on time. Wish you all the best. Thank you.